To introduce Nicole Siegal. She comes from Birmingham, Alabama. I guess she's been in Auburn for a while. She did her undergraduate studies here. She graduated with a degree in zoology in 2009. Her goal is to work as a general practitioner in Birmingham, working with small animals and exotics. And she's going to talk to us today about summertime and snake bites.
All right, thank you, Dr. Coe. Today I'm going to talk about summertime snake bites and a few different cases that we saw all within 48 hours that presented to us. So I'm going to start off just talking a little bit about snake bites in general, and then I'll go into talking about our cases. Pit vipers are the biggest group of venomous snakes that we see that account for the dog and cat bites around here. This includes copperheads, cottonmouths, and rattlesnakes. Identification of the snake can help decide on the treatment. So a lot of times the owner will kill the snake, and so it's really good to tell them if they bring it in with them, it'll help decide on the best plan of treatment. So venomous versus non-venomous snakes is important to see because if it's a non-venomous snake, obviously you're not going to go through with treating with antivenom and etc. So if you look at the eyeball, you can do this from far away without having to get too close, you can see that right here in this copperhead, it's got vertically elliptical pupils, and in this garter snake, it's got round. So you can see this from afar without ever having to come into contact with it and see that if it's got a round pupil, it's probably pretty safe. Also, it takes a little bit getting closer to, but you can look at the scales underneath their anal plates. Here is going to be a double row, and this is going to mean that it's harmless, and single rows will probably mean that it's venomous. Copperheads are responsible for most of the bites that we see presented to us. They're usually identified by this hourglass shape that you can see right here. Rattlesnakes account for the most deaths in human and animals. And you can see the rattle and hear it. So a lot of people wonder why we see the most bites during the summertime. And this is actually not because the venom is more toxic. The real answer is because the venom yield actually increases during the summertime, because in the winter they're hibernating and the venom builds up and they haven't eaten in a while. So come summertime they have lots of venom and will inject most of it during. So clients always ask you when they present to you, is there anything I could have done to prevent this from happening, or is there anything I could have done to make the prognosis better? The best answer to tell them is that your first aid treatment should never delay your trip to the ER. The only thing you can really do is immobilize the animal in the affected area so that you can prevent the venom from spreading. When snake bites present, they usually look at you looking all sad and with this serosanguinous fluid oozing from the bite like you can see right here in the alley, and with local tissue damage. The most common way to diagnose a snake bite is to see an echinocyte on the blood smear. All it takes is a drop of blood and putting it on a smear and looking at it under the microscope. This is seen in 90% of cases. So what you're going to look for when your snake bite victim comes in is you're going to look and see if they're showing any signs of shock, such as tachycardia, decreased blood pressure, etc. You're also going to look for prolonged clotting times. This is actually seen in 60% of the victims that present. You're going to look for hypotension by assessing blood pressure, thrombocytopenia, such as hemorrhages and melena. You're going to do an ECG to see if they have an abnormal electrocardiogram. You're going to look for lymphadenopathy and multiple organ dysfunction syndrome. So the treatment is mostly aimed, first off, at preventing or controlling the shock, and you're usually going to use isotonic crystalloids and assess the blood pressure as this goes on. You want to neutralize the venom, and the only approved treatment for this right now is antivenom. You want to prevent DIC, minimize the amount of necrosis, prevent secondary infection from happening, and use pure mu agonists, usually for analgesia, because this has the least amount of cardiovascular depressing effects. So there's lots of controversies right now in veterinary medicine about snakebite treatment. The first is antibiotics. Here in Auburn, we usually only use antibiotics if severe necrosis is seen. Although snakes' mouths are really dirty, The venom actually has some bactericidal properties, so it's usually not needed unless the necrosis is pretty bad. NSAIDs are, as a consensus right now, not recommended because they impair platelet aggregation, which is something you really don't need. Steroids are kind of iffy. Mostly, vets use them to reduce the swelling and help with the pain, but it also interferes with the healing process, so a lot of people are trying to steer clear of those right now. It's up to the vet, I guess, that you talk to on which one they want to do. Antihistamines, a lot of vets are under the approach that they want to treat with antihistamines before they do the antivenom, because they think that this is going to help control the anaphylactic shock. But here, at least, we say that we're not going to give antihistamines unless they start having a reaction to the antivenom. This is because of the hypotensive side effects, and we're already worried about hypotension in the beginning. Blood products, we say that you can give fresh whole blood if the packed cell volume drops below 20, but you don't want to give fresh frozen plasma, which a lot of vets do think that you want to do because they think, if your coagulation factors are low, that you should give fresh frozen plasma. But in recent studies, they found that if you just give antivenom, it will help reverse the coagulopathy rather than just keeping on adding coagulation factors. And the vaccine that is patented right now is only for the western diamondback rattlesnake, and it's not going to prevent the clinical signs from actually happening. All it will do is possibly lessen the clinical signs if your dog is bitten by only the western diamondback. So when to use antivenom? It neutralizes the venom of all the pit vipers, and it can reverse the coagulopathy, the fluid loss, and necrotizing effect of the venom. But the disadvantage is 7% of the patients that receive antivenom will have an allergic reaction. And this is because of the equine immunoglobulins that are used. And what they do is they inject the horse with the venom of different snakes and then pull their serum and use it to make this vaccine. But when they pull the serum, there's also going to be some albumin and protein contaminants. And this will cause an allergic reaction in some of the dogs. But the main thing that steers clients away from this is the cost. Here it's about $500 a vial. I've been at clinics where it's $700, $800 a vial. And when you're using, 1 to 3 vials of it, that can get very expensive. So how you're going to administer it, it comes in a 10 milliliter vial. You're going to dilute this with a diluent that comes with it and add this to 100 to 250 milliliters of crystallate. For 15 minutes, you're going to give it at a very slow rate to assess the TPR as well as check for erythema and et cetera to see if they're having an allergic reaction. If you see an allergic reaction happening, you don't have to stop giving the antivenom. You just slow it down and piggyback Benadryl with it. If no reaction is seen, you can slowly increase this and give it for 1 to 2 hours. So the prognosis has a lot to do with the first 2 hours after the bite. In the acute stage, if they come in and they're shocky, the prognosis is probably fair to guarded. But within the first 2 hours, if they're not showing signs of shock, their prognosis is probably good. So on to my cases. 5 snake bites presented to Auburn within 48 hours. 4 dogs were all from the same household, and one of them was totally separate. So meet Lucy, bite number 1. She's a 4-year-old intact female pit bull who her parents saw her digging outside in the brush, and 5 minutes later she came in and they started knowing the swelling and brought her in immediately. On Lucy, there was only 1 puncture wound found, and this was right above her nose where you can see this red mark. All of Lucy's diagnostics were within normal limits. She was given 1 vial of antivenom, she was kept on hydromorphone and fentanyl to help control her pain, and given 150 milliliters per hour of plasmide. This is 2 times maintenance, considering she was not shocky. She was sent home 24 hours later with an oral dose of tramadol and Clavalox. And the reason we gave her Clavalox is because she had severe necrosis around the bite and her swelling. And you can see here that the swelling has decreased, and it's no longer around her mouth, and it started going ventrally, which is normal for snake bite. So Sammy, bite number 2. Sammy presented to us with his other 3 siblings, and he was actually rushed back to critical care because he was showing profuse melena on his way back and arrested on the way back to critical care. He was actually revived and brought back to life, but while being triaged, while we were reconstituting the antivenom, we found that there was a snake bite on the tongue. So the venom was so quickly arterialized that he actually passed away before we could administer any antivenom to him. So this is Danny. This is the last one of the dogs that came in of the siblings. After the owner arrived home with her other 3 dogs that were in critical care, she noticed that Danny had facial swelling as well and turned right back around and brought him back to us. So on initial presentation, he was slightly anemic and thrombocytopenic, but everything else was normal. So we planned to administer him 1 vial of antivenom, hydromorphone boluses IV to control his pain, and plasmolite at 30 milliliters per hour. He was the first to go home of all of the dogs that were his brothers and sisters. He was hospitalized a total of 2 nights and received 1 vial of antivenom. He was sent home with a fentanyl patch, tramadol, and famotidine. And this is him. About a week later, you can see where his fentanyl patch was, but everything else on him has gone completely back to normal. His mom has told me that he still has night tremors because he dreams about it, but other than that, I think he's gone back to normal. So this is Conley. This is bite number 3. This is Danny and Sammy's sibling. He's a 5-year-old male castrated lab who presented with 4 puncture wounds, 2 on each side of the mouth. And he was very, very painful in presentation. He wouldn't let us clip the wounds or even really get near him to assess. So on initial presentation, he had a stress leukogram, a just very mildly elevated alk phos, and an increased creatinine kinase. We initially managed him with bolusing a total of 400 milliliters of plasmolite because we couldn't even find his pulse to assess his blood pressure. So after 400 milliliters of boluses, his blood pressure was able to be found and started to normalize, so then we maintained him at 75 milliliters per hour. We also were giving him hydromorphone boluses to control the pain. 24 hours his swelling had not gotten any better at all, and so we started on intoxifiling. It's an immunomodulating agent that helps control the swelling, and it actually did help. So after 3 nights in ICU, Conley was discharged. He received 1 vial of antivenom and was sent home on Flavonox, intoxifiling, and tramadol. And this is how handsome he looks today. So the last case that I'm going to talk about is Allie, bite number 4. She was one of the many siblings that we've talked about, and she was probably the worst out of the ones that survived. She was an 8-year-old female spayed terrier who presented with an erythematous and swollen 3rd eyelid, as you can see in this picture. She had draining puncture wounds above and below her eyes, and bilateral marked facial swelling. So on initial presentation, she had an increased packed cell volume, total protein, and hyperglycemia. Her chemistry had lots of changes to it, but most of it was because of the leaky vasculature and the edema formation. And her coag profile had an increased PT, APTT, and fibrinogen. So we decided, first of all, we ended up bolusing her with a total of 450 milliliters of plasmolite, which is a lot for this small dog. And the main reason for that is also because, like Conley, we couldn't assess the blood pressure. So once we could assess the blood pressure and it began to normalize, we slowed that down and we're giving her 32 milliliters an hour of plasmolite. She got 1 vial of antivenom, and she started on a fentanyl CRI. And the reason she was the only one who got the fentanyl CRI is because she was the most painful out of all of them, and she would not even let you get close to her. So 24 hours after the bite, on doing physical exams, Suzanne noticed that there was an asynchronous femoral pulse and heartbeat. So we did an ECG and saw that it was due to ventricular premature contractions. We did end up treating it because she wasn't showing any clinical signs of hypoperfusion or decreased heart function. If her VPCs would have been multifocal or she would have started showing any signs, then we would have treated her with lidocaine. So on day 2, Allie was still in the same exact boat. She hadn't improved at all, so we gave her another vial of antivenom and started her on Voluben at 13 milliliters an hour to help provide oncotic support, and continued her on plasmolite. Day 3, there still wasn't much improvement, so she was given 1 more vial of antivenom, totaling 3 vials. So Allie's healing process was much slower than the rest. She was discharged from the hospital after 5 night stays and 3 vials of antivenom. After being discharged, she keeps going to her referring veterinarian for a checkup, and her owners have done a great job keeping me posted. She was actually supposed to be here, but I don't think she made it. At her referring, she became very anemic and her liver values went sky high. So a blood transfusion was mentioned, but in the end she ended up regenerating enough red blood cells that it wasn't needed. Her wound was debrided because of all the severe necrosis, and a drain was placed. And she kept the e-collar on, I think, for a total of 2 weeks. So today, Allie's right eye still has no PLR, and only time will tell if her sight's going to return. Her other eye is 100% functional, so she's still going to live a great life, and she's almost done overcoming this terrible battle. And I talked to the mom recently, and she actually told me that Conley, the black lab, got bitten again. about 2 weeks ago, and that he visited the referring and everything's okay now, and she's had a professional herpetologist come out. She's hired so many people and no one can find any snake beds or anything along those lines. So she's just going to try to keep the dogs inside as much as possible and keep her fingers crossed. So those are my references. And I want to thank Mrs. Kathy Barnes. I don't think she made it here, but she was awesome. She's informed me so much throughout this process. My wonderful family, my grandparents and my dad for coming. Dr. Basic and Dr. Coe for all their guidance, and Dr. Christofferson for giving me those images.